hyped, so I'll try to be really good about slowing that down a little bit, but if I go too fast or you can't understand something, please just tell me. This lecture is typically 2 hours. I'll try to be quick and shorten it since I know you guys have already been waiting on me for a little bit. But the other thing is just to say I'm now at Lakeside. That's the only change to this, is I'm no longer at the University of Oklahoma. I went into private practice last October just to have more time at home with my kids and the one on the way. And so I now kind of have an understanding of both the academic world and the private practice world. I will say I see a lot less high-risk obstetrics in the private practice world. Not that I still don't see quite a bit, it's just that I see less, and I didn't really kind of understand that or how it would be that dramatic, except for that I don't get worked up about half the things my partners do because that's just my norm in my mind, whereas they're like, oh, this lady's got diabetes and hypertension. And I'm like, okay, all of it. And so we're going to kind of talk about all of those things that can really impact a pregnancy. So we're going to, it's not just about the end of pregnancy, this is also about the beginning. So we're going to talk about miscarriage and that kind of thing too. And just kind of describing the more medical terminology. So miscarriage is very much a layman's term, right? And not a word that you usually use as a healthcare professional. But we use the word abortion as a healthcare professional, and that's hard sometimes for people to hear or talk about. So it's going to be something you just kind of have to learn to interchange in your vernacular. And we'll kind of talk about those kinds of things. We're also going to talk about placentas. We're going to talk about bleeding, and then hypertension, diabetes, as well as some depression, because that's a really big deal as well. The only side note I'm going to add is I am going to talk to a smidgen about obesity that's not in this PowerPoint. And the reason being is there's a lot of new data out there that says that this is going to be a big deal. We don't know exactly how much it's going to affect the way we practice, but I think it's worthy enough that I should spend 2 minutes kind of talking about what we think is coming, because it's likely going to impact the way you take care of people in your practice, even though it may not be on an exam right now. We're also going to talk about preterm labor and preterm rupture of membranes. I kind of lump those together because they're actually treated very similarly with very few changes. There is one big change about steroids in pregnancy. I did not change it on the PowerPoint, even the one that I didn't send her to upload for you, because it is not going to be changed on any of your exams yet, but it is changed how it's used in clinical practice. So you'll get a side note on that as well. I have no disclosures, I'm just me. And we're going to start with ectopic pregnancy. So this is the good with the bad. People a lot of times are trying for a pregnancy, they're very excited, and then they get hit with this bad news that the pregnancy is not where it should be. Let us first say that in the state of Oklahoma, this is a difficult conversation for 2 reasons. There are a lot of people that think, why can't you move the pregnancy for me? They don't understand that that's not how it works, right? Like, you and I don't know how a placenta attaches. I definitely can't unattach and reattach one, despite what people in the Senate tend to think. Secondarily, if I am removing an ectopic pregnancy for someone's tube, you're going to see a lot of things on Facebook that will show you videos of ectopics. Don't get me wrong, I don't care what your political views are, I don't care what your religious views are. I will tell you all about mine if you want to know, but it doesn't matter. Do you know what I mean? Like, it doesn't affect the way that I practice. I will say that I grew up in a very small town, Oklahoma. I grew up in a very Christian household. I spent my entire world, growing up in that way. Do I still go to church? Yes. And so I'm affected by this a lot because personal beliefs and just flat out science are different. And you've got to be able to separate that in your mind. It makes no difference what I would do in my pregnancy, in my scenario. What my job as a healthcare provider is to provide them with the options. Now, that is not to say that you have to do anything ever in your career that you are uncomfortable with. I do not perform elective terminations. Do I tell people where and how that they can get them if they want them? Dang skippy. Because what my primary goal is to make sure they're not in the back alley somewhere dying from an inappropriate procedure. So the only reason I bring any of this up is because it will, if you are going to practice in the Bible Belt, this is going to be a part of your healthcare problems. I literally had people say to me, like, I don't understand how you could remove that baby that you could see that was moving from a tube. And I'm saying, and in my mind, you're right, it hurts. And I don't like it in the sense that I'm very sad that there's nothing I can do to save that baby. But what I can do is save the mom, so she can take care of the babies she has, and she can make new ones if she wants. And so you're going to run into that stuff a lot. So this is all, from here on out, just about the science, okay? It has nothing to do with the way I think, I believe, or the way I'm trying to make you think or you believe. I just always think this deserves a 60-second stop to just briefly mention, because it will come back to you at some point. So this happens when that blastocyst, or that developing fetus, implants somewhere other than the endometrium of the uterine cavity. Most of these cases are going to be the fallopian tube, okay, more than 98% of them. Hemorrhage from ectopic pregnancy, and this is bolded and underlined because this is why it's important. It is the leading cause of pregnancy-related maternal death in the first trimester. It is a huge part of maternal death in the US. So that's the other thing you're going to see right now, right? Is I apparently in the news am a really bad guy. I'm an OBGYN, that means I don't care about people, I let people die. We're bad currently. There is a huge national movement towards looking at maternal morbidity and mortality, and the gut reaction is, why am I not fixing it on the regular basis? Well, I hate to break it to you, you're right. We do have bad rates of this in the US. You want to know why? We're fatter, we're older, we're diabetic, we're hypertensive, and we're a lot of other things that they aren't in other, like, developed countries. So our risk is higher. So the other thing is we track this stat in a totally stupid way. Maternal mortality is tracked by any death within 12 months of being pregnant. So you have an ectopic pregnancy, you die in a car wreck 6 weeks later, maternal death. That, I mean, you know what I mean, like that makes no sense. You had a totally normal live-born SVD, you die and your husband shoots you 6 weeks later, that is a maternal mortality. So we don't track it the same way that Sweden or some of the other countries that have better rates than us do. So, but this is important because this counts in this. So you not treating or not knowing or not seeing an ectopic, because a lot of primary care people, you're going to see people in ERs or urgent cares or whatnot, and every single woman from 12 to menopause, 9 to menopause is pregnant. They're all pregnant until you prove that they're not, okay? They walk in and their complaint is nose itching. They're pregnant until you prove that they're not. And that is because I've delivered a lot of Jesuses in my day. People that have never had sex, who could never be pregnant. But it happens a lot. People get started on medications that are inappropriate. I have 32-week fetuses diagnosed by MRI scan all the time. Don't be that person, okay? If I teach you one thing today, literally that's the most important thing I can teach you, is they're all pregnant until you prove they're not, even if they say they can't be. Particularly if they're young and they have a older relative in the room. So 4 to 10% of pregnancy-related deaths are related to ectopic pregnancy and hemorrhage. These are risk factors. Essentially, most of the time I'm not going to read you guys risk factors and all these because I'm relatively certain that you can read or you would not be here. But in this instance, the way I want you to think about them is that there's something that messes with the tube. Okay? So you've had a previous tubal surgery, you've had PID, you've had an infection, you do a whole bunch of weird things like douching with vinegar and bleach and all the other things I try to tell people to stop doing to their vaginas. By the way, self-cleaning oven, don't stick stuff up there, it's fine. I'm always telling people to not do that. But it messes with everything. 2 things that you can remember in obstetrics, if you are on wards or rounds and you're looking to look like a rock star but you have no idea what a risk factor is, smoking is a risk factor for essentially everything. Previous whatever is a risk factor for whatever. So previous ectopic, risk factor for ectopic, previous preterm labor, like it literally always works, okay? The only time smoking doesn't work is preeclampsia, which makes no sense because you would think smoking would increase high blood pressure rates, but it doesn't. But otherwise, smoking and previous whatever always work. The other thing that's probably a 90% bet is an extreme of age. Less than 16 or over 35. Welcome to being an elderly pregnant woman, because I'm 36. Let's also be clear, I don't think a girl came up with that ICD-10 code, sorry, to all the men listening, but I don't think any woman was like, I know, we should call ourselves elderly. Get pregnant. No. I get so mad when I circle that every time on a bill sheet. Anyway, I can't help myself. Must remember normal anatomy in order to remember what is abnormal, okay? So this is just a slide to remind you guys the different names of the different parts of the tube, right? Because when people are getting real specific about pregnancy, they're not just, or ectopics, they're not just going to talk about is it in the tube, they're going to talk about what portion of the tube that it's in. You can have ectopic pregnancies outside of this. You can have them on the ovary, you can have them on the cervix. You can have them in the abdominal cavity. I had one implanted into the omentum that I had to deliver at 18 weeks. It was horrible. That was like a full baby. But mom was dying, and it was implanted into somebody's omentum. I mean, it was just crazy. Those are really super rare. Out of my 10 partners, only 2 of us had ever seen one, and the other one saw it in residency 45 years ago. So that's not going to be things like it's going to probably be in the tube. Next case scenario in the ovary. The things that you're going to see more of are cervical pregnancies. They're on the rise because of assisted reproductive technology. And then the other thing that we're seeing a lot of is cesarean scar ectopics. So this means that it is not implanted in any part of the endometrium. It literally found that one tiny line of scar implanted just into the scar and is probably ballooning out on both sides of the uterus. So essentially, if my head was the uterus, like it's a little bit on the inside, but it's also growing outside into the abdominal cavity. Those are also pretty much non-viable because they outgrow their blood supply and they rupture, and they're going to have a really high mortality rate for mom. So this is the locations that we talk about. Most of those I just spoke of. 70% of ectopics are going to be in the typically in the ampullary portion or infundibular portion of the tube, with 90-some-odd% of them being tubal by themselves. That number will probably, like I said, go down because you have hysterotomy scar and cervix on the rise. We don't have new data to say exact percentages for exact places yet. The other word you'll hear is corneal, so that means it's literally implanted in that where the tube goes into the cornea of the uterus. This is different, a bigger deal, because you typically have to cut into the uterus to get that, but it's in that tiny skinny portion that can't grow with baby, okay? And then heterotopic pregnancy is just a word I want you guys to know about. It is exceptionally rare. 1 in 5,000, I think, was the last quoted number. You guys don't need to know that. But it means that there is an ectopic pregnancy along with a viable intrauterine pregnancy. This obviously changes the way that you can treat them, right? Because medicines that you would use would affect both pregnancies. Here are some pictures just so you can see. You will see some that look just like blood and tissue. You will occasionally see early embryos, but like that middle one, I mean, that baby's like 10, 11 weeks, okay? So it has arms, it has legs, it has fingernails, you can see its eyes. This is tough, and this is why it's a hard subject. But you cannot survive past about 14 weeks, usually earlier than that. You will very rarely see one over 11 in a tube, okay? Which is where most of these are. And this is why it's a touchy subject, and that's why I bring these photos, because I want you to know it's not just a glob of nothingness. It is typically very, unfortunately, when you're having actual pictures in a surgery, it's big like this. Medication and things only work when you catch these things early. So diagnosis is dependent upon a combination of their beta-HCG and ultrasound testing and a clinical picture, okay? This is one of those times where there is not a 1 + 1 = 2. It's not ABC. This is clinical acumen, clinical judgment. There is no perfect answer sometimes, particularly when you're early. You can be very suspicious of ectopic pregnancy with a small adnexal mass and a quant of 500, but I'm not going to see a live baby with a heartbeat with a quant of 500 on ultrasound, right? So you can't always know for sure, but you can have a very good idea. And you really, really, really have to treat mom, not just the pregnancy that you're trying to save, okay? Because more importantly, if you don't save mom, you have no way of saving the pregnancy, right? Any woman presenting with a positive pregnancy test, any kind of abdominal pelvic pain plus or minus bleeding should be characterized in your mind as an ectopic until you prove that they're not, okay? So people should never really, you shouldn't assume that things are normal and only worry about them being abnormal if they get worse. You should assume it's the thing that could kill them and give them the appropriate precautions and workup for that. Clinical manifestations, the funny part is you're going to get both amenorrhea and vaginal bleeding, right? Because they were amenorrheic, that's how they figured out they were pregnant, but a lot of times now they also have spotting or some kind of vaginal bleeding to go along with their pain, which is what's probably brought them to the doctor or the ER or wherever they are. You may see signs of hemodynamic instability and or an acute abdomen. That's where you're really getting into trouble. Because if they are hemodynamically unstable, they have lost a ton of blood, right? Because pregnant women are young and they're healthy. And there are those people that compensate, crash. So by the time they're crashing, you've probably got liters in their abdomen. And so just because somebody's blood pressure is still hanging on to the normal range and they're maybe tachycardic doesn't mean you can be like, oh, their pulse is only 98 from 68. That's still normal. Like that needs to be triggering like thought processes in your head of, ooh, what does that mean? And a pelvic mass may or may not be palpated on by manual exam or may not be seen on ultrasound. It just depends. There's a differential diagnosis here that's super long, right? Essentially anything that can cause, I mean, you guys learn like when you're on surgery or when you're talking about abdominal pain, they like have you divide it by quadrant, right? And like talk about what are the things that are in this area. So in my world in pelvic pain, because I get two of those quadrants, right? Below the belly button on either side, I think of it more as like an organ system thing. I'm always like, what is it in my system that can hurt people? You know, their uterus and their tubes and their ovaries. Once I've ruled those things out, then I'm thinking about GU, so urinary, kidney, ureters, that kind of thing, GI. And then there's also going to be like musculoskeletal issues, and then you can never rule out the supratentorial issues as well, because that plays a big role in any kind of pain processes, right? So I've divided this kind of into like the pregnancy-related conditions and the non-pregnancy related, and the things that are going to be the most common. Because just because they're pregnant doesn't rule out like other things that you see in GYN, like a torsed ovary, right? And they're going to have more of a reason to have one when they're pregnant because they're going to have a corpus luteum. And is it 2 centimeters? Then it's probably not going to torse on itself. But did it bleed a little bit and it's in that 4 to 8 centimeter range? Then it could very well twist on itself because of the weight. So it's just to make you think, like you don't want to, just because you know they have a positive UPT, assume that the only thing that could be causing them an issue is that pregnancy. HCG is, in 85% of viable pregnancies, raises, we think about 66% every 48 hours during the first 40 days. There's new data coming out of the REI world because these are the people that are stalking HCGs, right? Because these people know they're pregnant like the second they're pregnant. That says that may not be accurate. That may be old. It may actually not rise as much as we think. Therefore, in today's day and age, if it rises about 40%, we're okay with that. But this is still what your book is going to say. But I think that may change over time. Essentially, the way to think about it that's easy to remember for the rest of your life is doubling every 48 hours. That's like the easy, if you don't want to remember a number when you're not actually an OB, because, I mean, don't get me wrong, what I do is awesome, but I know not all of you are going to do it, and that's silly. And so that's the like phrase to remember, doubling every 48 hours. In an ectopic or a non-viable pregnancy, it's typically going to drag. It's going to kind of go slower, the peak is going to be lower, it's going to plateau and kind of do one of these numbers as opposed to just being a straight arrow kind of upward. And a failing or a falling HCG is most consistent with a failed pregnancy of any kind, but that actually doesn't tell you if it's intrauterine or not. It just tells you this isn't viable. But I've seen a ruptured ectopic with a quant of 12. Like it fell and fell and fell, and so we thought, oh, this might be from like 600 down. We were just following it because we could never figure out where it was, hoping it was intrauterine and presuming it probably was, because most of them are. And then she came in with blood in her belly and a quant of 12 and a ruptured ectopic on one side. So it's just to tell you, you really have to pay attention the whole time. So there are 2 treatments for ectopic, medical and surgical. Specific indications for surgery are going to be anytime you're worried about mom being stable, right? So hemodynamic instability, if you think it's ruptured, if they can't have methotrexate, because that's the medication of choice, which is a chemotherapy drug, and so it has to be given in a certain way by a certain nurse in a certain place. It's sometimes hard to get. Coexisting intrauterine pregnancies, so that heterotopic I was talking about, you obviously can only surgically manage those. If somebody is a poor medical therapy candidate, so I don't really get those anymore at Lakeside. My patients are reliable. They typically come to the doctor again. But at OU, we would get people that don't have any health insurance, that are homeless, that don't have a ride or transportation. So if you can't come back and do the follow-up that's required for the methotrexate, you shouldn't be given the methotrexate, right? So those are just things you have to think about. The other thing is if somebody, I had an ectopic after a failed vasectomy, right? So that woman was like, for the love of God, tie my tubes too, because I don't want to end up here again. And I was like, surgery it is for you, we'll do it all at the same time. So a desire for permanent sterilization might move you towards surgical management as well. And then known tubal disease, especially if they're planning in vitro, because tubes that don't function or don't work right can actually decrease their success rates in IVF. And then if they failed medical therapy, right? So if we tried it the way that keeps you out of the OR, we may have to end up going there if it doesn't work. Methotrexate is a drug that gets brought up in my rotation a lot. It gets, typically people ask, not really usually about the dosing, which is 50 milligrams per meter squared related to body surface area. But it's typically one of those drugs where you get the question of like, how does this work? So this folic acid antagonist portion, meaning it inhibits the DNA synthesis and cell reproduction, and the more the cell is proliferating, the more focal it works on that, aka an early pregnancy, the better that is. So that's probably the most important line on this slide. It is rapidly cleared by the kidneys, but it also goes through the liver. So they need a CMP prior to giving them, because if they don't have good kidney function or they don't have good liver function, they shouldn't be getting methotrexate. Surgical management can be laparoscopy. That's usually typically our goal. We like to do as much as we can laparoscopically these days. But if you can't see, or there's too much blood, or it's too big, or the patient's actively dying, opening may very well happen. Generally, the laparoscopic would be the standard approach. There's a lot of argument about, well, what do you do once you get in there? Do you make a cut in the tube and try to remove the pregnancy and leave the tube, which would be a salpingostomy? Think of it just like an ostomy here. You're making a hole. Or do you just take out the damaged tissue? You take out that whole tube so they don't get another ectopic in that one. There is no right answer there. You can get a lot of argument from either direction. I think that it depends on age, what they want for childbearing status, whether they have a normal appearing other tube. If the other tube looks really abnormal, then you definitely don't want to take either tube, because you're going to hope that they have one that can get, can achieve a pregnancy later. And like I said, it's controversial. Post-surgical follow-up is, especially in medical management, you want to watch a beta-HCG go down to 0. And that's because, like I said, it can rupture at any time. So you don't just say, oh, you were 20, that's like way better, we're done following you. All the way to 0. It's annoying to patients, but you would have to just kind of explain the why. And or if they're having a surgery, typically it's after they've recovered from surgery. Depending on exactly what you did, the medication versus the surgery will depend on exactly how long they need to wait again to get pregnant, but it's usually not more than a cycle or 2. So gestational trophoblastic disease, this is a fancy word for kind of all of those things where the good gets bad. So good pregnancy tissue has now turn on itself and is kind of attacking your body in some way. It's a proliferative disorder of those trophoblastic cells that are in the beginning of the pregnancy cycle. It's defined, there's a pen right here. It's defined by a distinctly, by the tumor marker beta-HCG. That's how you're going to follow this disease process. And it's unique. So it is essentially a maternal tumor or problem that arises from gestational or fetal tissue rather than from your own maternal tissue. So you don't see that a lot. There are several histologically distinct types. There are moles. So Hepatiform moles are complete or partial moles, and we'll kind of talk about that in a minute. There is persistent, or otherwise known as invasive, gestational trophoblastic neoplasia, so an actual cancer from these disease. There's choriocarcinoma, like another type of cancer from the chorion of the placenta, where there's placental slight trophoblastic tumors. Essentially, again, risks. Smoking's on there, extreme of age, etc. You are less likely to get it if you are blood type O, and more likely to get it if you're A, B, or AB or AB. The positive negative part doesn't matter, but O's for some reason are significantly less likely to get this. We don't know why. And then people that have been on birth control pills, that has a higher risk than other forms of birth control, but we're talking about, like, for the love of God, don't stop your birth control pills because of this. We're talking about really small numbers here. Clinical manifestations are going to, again, be bleeding. The difference here is you're typically going to have an enlarged uterus because this grows rapidly because of that rapid proliferation. It usually also doesn't feel like it's when you think somebody's 7 weeks pregnant and their uterus feels 15, you're like, that's not quite right. They also are more likely to have these big giant cysts on the ovaries, kind of maintaining hormone levels because of all the beta-HCG, so that's that Corpus Luteum cyst. They're going to be more likely to be anemic, and then because of the super high levels of beta-HCG, they're going to be more likely to have hyperemesis, and they're going to be more likely to be hyperthyroid. Because if you guys don't know, beta-HCG and TSH kind of mimic each other, and so people with these issues, those things kind of go hand in hand. Also, people do not get preeclamptic prior to 20 weeks. It's just not really a thing. So if they do, you're really concerned that something's not right, particularly that they may have some kind of gestational trophoblastic disease. And then they can have vaginal passage of these hydropic vessels. And so meaning the vessels of the placenta, they get really swollen, filled with fluid, and kind of break away from the placenta and can pass through the cervix and be passed vaginally. That does not happen very often. So this I love. If you can't tell, it came from Up to Date because it's got that like green line across the top of it. But I think this is a super helpful slide about partial moles versus complete moles. In my world, and like lots of, when people do our OB rotation, when they take the self exam or on a lot of our board exams going through, this tends to be a popular topic for an OB question because it's easy for people to be like, this is the scenario, what is the diagnosis? Is it GTD? Is it a partial mole? Is it a complete mole? And then they throw in a couple like, is it a pink cup or whatever that don't make any sense. But essentially the thing that had made it easiest for me, because this is backwards a little bit of what I think that it by word makes sense of, is that a complete mole is a complete set of chromosomes like you and I. It's 46XX or 46XY, mostly XX. Whereas a partial mole, you would think then would be like less chromosomes, right? But it's actually a triploid. So it's more. It's partially molar and more likely to have an actual fetus. So typically, that's the way I think about it, is it's partial mole, partial baby. So a lot of times that's the one with a baby in it and then extra molar tissue. Whereas a complete mole is just molar, yucky shenanigans and has the complete set of chromosomes like you and I. That is not that's not going to be in a book anywhere. That's just me trying to help you delineate something in your head because it was very helpful for me when it was explained that way. So this is going to go through and talk to you about like how much of these are going to be persistent, how much are going to go on and develop into a cancer. So that complete mole is much more likely to be persistent. It's much more likely to cause a cancer as opposed to a partial mole. And then it talks about the karyotypes, and it talks about their incidence rate at the top and kind of compares the two. So management of moles is you need a preoperative or baseline HCG because you need to know where you're starting from, right? You need to know, because then your follow-up, you need to know, did it drop a lot? Was that good or was it not? Labs ruling out any concomitant morbidity, so CMP and things that have to do with the liver. And then you need to figure out if this is essentially surgical management is standard of care here, because you need to evacuate that tissue as quickly as possible. So typically this is done by a DNC. You send that down to pathology to know for sure what your pathology diagnosis is, and that way you're getting rid of the tissue that's creating the problem. And you follow beta HCGs serially after treatment. And then you don't need to memorize this, but this is not like an ectopic where you just follow it down to 0 and call it good. Most of the time these people need to be 0 for 6 to 12 months, depending on what they are, before they try again. And that's because you can be 0 and the next month be 20 without ever having intercourse again. So you have to make sure that the tissue really does stay gone, not just fool you into thinking it has left. Spontaneous abortion, remember this is the same phrase that people use for miscarriage. This is something that is just going to show up in so many walks of life, right? 40% of women will have one at some point in their life, so that guarantees that almost, that a significant number of us in this room have either had one or will have one. You will likely have a family member that either has one or has had one. But it's not something talked about in our society a lot, right? So it's something that women typically tend to feel like they're going through alone. You as a healthcare provider will see it, and you will see people dealing with the consequences of it in pediatrics possibly, in family medicine, in internal medicine, in psychiatry. You are going to see it for sure in an ER or an urgent care, and you're dang sure going to see it in women's health. So it's just going to bleed into a lot of different things that you may do with your life. It is just by definition any loss less than 20 weeks. Now, is a loss at 18 weeks the same as a loss at 6 weeks, or the same as a loss after, bleeding from a positive HPT? It's hard to know. Like physically I would say no, but emotionally those may be very similar for different people. And so one of the things I just really encourage people to do is not judge. And I'll tell you this story for that reason. So between my daughter and this daughter, we had a loss last fall. I was only about 6.5, 7 weeks probably, but let's be clear, I knew my positive pregnancy test about 2 days after my missed period. So that was a couple of weeks of knowing and being excited. Followed my quants because I didn't have a normal ultrasound, and they rose at first before they dramatically did not rise. And it was no more than a really horrible, heavy menstrual period, But when I went to my OB for this pregnancy, and she said, do you want me to put G2P1 on there, meaning, 2 pregnancies, 1 live birth, or what? I was like, no, I'm a G3, I was very, and I had no idea that would be such a strong reaction from me. If you had told me before, I'd have been like, whatever. But it was very, why would you ever take away what had happened? And so you just have to be very open to letting people react to this however in the world they want. Whether that is sometimes relief, because that's not what they wanted in their life at this time, because then people get really upset that they're relieved. You know what I mean? And you have to just kind of validate any of those responses. It is the most, I don't think commonest is a word. Commonest complication of really. Anyway, I went to Harvard in school. I made one up. Most common, I think, is one word. We'll roll with commonest. My hillbilly husband's apparently went off on me. I'll have to tell him that when he gets home. He's going to love it. Anyway, its frequency decreases with the increase in gestational age. So the earlier in pregnancy, the more common. Once you see a baby with a heartbeat on an ultrasound, a lot less common than before you can see those things. Again, risk factors, things you love, like the smoking and the age that I talked about. I do want to address two things. One, some of the medications or drugs. I mean, not cocaine, let's be clear, don't do that. But NSAIDs and caffeine, this is not, so people that take really high dose NSAIDs every single day when they're attempting to get pregnant, that is one thing other than the whole like, I haven't missed a period yet, I took a single dose of ibuprofen, like no one cares. I was 8 weeks pregnant, had a bad migraine, and I thought, totally taking ibuprofen today, and did. Because a few doses here and there are probably not that big of a deal. It's repetitive use. The other thing about the caffeine thing, because let's be clear, as I sit here with my jug of unsweet iced tea, that I did not give up caffeine in pregnancy. This is a study that correlates 200 milligrams or more in the first trimester with loss. So that is, like, let's be clear, I am very well aware that this jug of watered down iced tea probably has real close to 200 milligrams, but I'm also like 9 days from delivery, so I don't care, I'm tired and cranky. But in the beginning, I was careful about how much. Now, I don't drink coffee, so I don't know things about like a cup of, I don't even know what the words venti and whatever fancy words you people use mean, but I am very well aware of that a can of Diet Coke has 40 milligrams of caffeine, but a can of Mountain Dew has 54. A 20 ounce of Diet Coke has, because that was my, thing of choice until in pregnancy I hated carbonated beverages and had to switch to tea. But you will learn whatever your drink of, choice is. But generally speaking, people can have 1 to 2 cups of coffee a day unless you are drinking some kind of tar that is mimicking coffee. But I just say that because what I don't want people to leave my lecture and be like, oh my God, I want to have a baby, I can't ever drink a soda again. Because that would make me very sad for you. Our job and our schooling is hard. You probably need caffeine, that's all I'm saying. So maternal weight is also factored into this. It used to just be this BMI thing, and they say a BMI greater than 18.5, aka everyone in the entire world. It's the most stupid, anyway, it annoys the crap out of me. But as you increase that, BMI greater than 35, it increases, 40, it increases. Same thing with extremes of age, so less than 16, more than 35, but increases again at 40, increases again at 45. Though I have, in fact, delivered a 54-year-old. So chromosomal abnormalities is going to be by far the most common reason. There's also going to be congenital anomalies or trauma. This is not like, oh, I was 7 seconds pregnant and I fell on my bottom. This is like I had something done to my uterus, or I was in a major car accident and I fractured my pelvis type of trauma. Also, CVS and amniocentesis have increased risk for loss. Host factors, meaning the mom has some kind of issue like a clotting disorder. And then there's just ones that we don't know and don't have a good reason for. Chromosomal abnormalities are 50% of them. These are the way they kind of fall out. I don't necessarily think that's something you have to memorize, but I just thought it was interesting. Most are de novo, and they're rarely some kind of inherited karyotype abnormality. Host factors are going to include anatomic ones, so things like uterine septums or polyps or fibroids, and also infections, right, like your torch titers, which is most of what's listed up there, or endocrinopathies, so people with, and this is not, if your stuff is well controlled, your endocrinopathies are probably not going to be nearly as problematic. But if you come into your new OB with a hemoglobin A1C of 10, that's going to be a problem, right? I had somebody with an uncalculable TSH. I have no idea how that kid survived and that it's normal, besides whoever it is that you personally believe in. For me, the good Lord, I just can't explain that. Like, her TSH was greater than 250 at her new OB. Like, the lab couldn't calculate it. So it just sometimes works anyway, but most of the time that's going to be a problem. PCOS gets listed in there because it just, like, those people have a harder time getting pregnant and are usually borderline for other things like insulin resistance, so they have a slightly increased risk. But again, not the same as people that come in with a hemoglobin A1C of 12. I had one 2 months ago with 11.7, which hurt my head. Teratogens, so things that you work around that are, or medications that you take that are not good for early pregnancy can be a problem. So that's why we do encourage women to come for pre-conceptual visits. It just doesn't happen all that often. But if you are yourself are planning, I would suggest you check those things. Like, do you work with something or do you take something that you shouldn't be before you try to get pregnant, not after your positive pregnancy test. And then hypercoagulable states. So you have lupus or antiphospholipid antibody disease, or if you have some kind of thrombophilia, you're going to have a harder time. But there are things that we can do now, like daily aspirin and early Lovenox, that help these people decrease their miscarriage rates. Clinical manifestations, again, you're going to get that amenorrhea and vaginal bleeding, right? And it's more like a one than the other, not... At first I thought, did I turn my phone on? Because our group, the way that we communicate is a HIPAA compliant text messaging system called Tiger Text, and it literally growls, which I kind of enjoy. But I was like, is that? So loss of fetal cardiac activity, obviously pain, and then a cervix may or may not be dilated. You may or may not see products of conception. You can also have a completely stone cold normal exam and a loss. So this slide is probably what I think is the most important slide of the miscarriage slides. And I would say that because it lists all the types. So these are the types of abortion. Is it a missed abortion? Is it a complete abortion? Is it incomplete? Is it threatened? Is it inevitable? And it tells you about the vaginal bleeding, cardiac activity, cervical dilation. But what I want you to kind of understand is, what do those words mean? So a missed abortion means people have no idea. They've come in, they're there for their routine ultrasound or their routine visit, and they didn't know anything was wrong, but that pregnancy is no longer viable. So it either just didn't have a heartbeat, it stopped growing at some point, something, okay? So it's missed, they didn't know. Is it complete? Meaning they were pregnant at one point, you saw it on an ultrasound, or it was documented in some way, they had bleeding, they came in for an evaluation, and now there's nothing there. It's totally done. It's completed. Whatever bleeding they had cleared the uterine cavity. Incomplete. They had significant bleeding. You no longer see, so the most common example that I see of that is somebody had a baby with a fetal pole that's 6 to 7 weeks with a heartbeat, a gestational sac, and the little, products of conception implantation site. The sac and the baby are gone, the products of conception or that placental kind of tissue is still there. So part of it has come out, but there's still stuff in their uterus. Retained products of conception. Threatened, I'm going to skip for 1 second because it's the one that I deal with so commonly and makes me want to enucleate an eyeball. And inevitable means this is going to happen. There is nothing I can do about it, but it hasn't completely happened yet. This is most commonly when a gestational sac has collapsed on a baby. There's significant bleeding all around the sac. There's bleeding coming out of the woman's uterus, and they can still see that low heart rate trying to stay on ultrasound. This is the horrible one, because this person looks at you and is like, there's still a heartbeat, save my baby, what can I take, what can I do? And you can't fix it as much as you want to. Threatened abortion is the terminology for any vaginal bleeding in a pregnant woman in the first trimester. Hence the hatred of the word. Because you had one spot of bleeding one time on one tissue, you are technically a threatened abortion. And so anybody that gets an early ultrasound for spotting or any kind of treatment for spotting, that's the diagnosis code that it always gets labeled under. So say you're Rh negative and you call me with spotting and everything is normal, but I have to give you Rogam, I have to document that under threatened abortion. Women lose their shenanigans about that. So you have to, I will stop a visit and say, let's be clear, this is the code I'm entering because that is the medical diagnosis. This does not mean I think you're having an abortion. This does not mean I think you want to have an abortion. This is the fancy doctor word for threatened bleeding in the first trimester. And so that's the important part, because a lot of times what will happen is somebody will present like a scenario, and then it'll give you all 5 of these options as an answer choice, and you're supposed to pick what that scenario fits. Are they a threatened to complete, a missed, or whatever? Septic abortion is the only other one, and it gets brought up because this is the badness. So this means that is now infected in there. Like either they thought it was all gone and it wasn't, and so there's retained things that are infected, or somebody went somewhere and had a procedure but didn't, like all the tissue didn't pass. There's 1,000 different reasons, but these people are septic, they're really sick. So this is like sepsis from products of conception, whether that was an elective abortion, a spontaneous abortion, it does not matter. It just means they are now very sick from this. They're usually tachycardic, tachypnic, they have a white count. Their uterus is boggy, their cervix is dilated. So it's essentially like if you try to flex your bicep for forever and there's like some wound infection in your arm, like you're not going to be able to flex, it's just going to be floppy. That's what your uterus is doing. Most commonly it's staph or a gram-negative rod. It can occasionally be a gram-positive cocci, but most of these are going to be a mixed infection, right? Because the normal bacteria of your uterus is not the normal bacteria of your vagina, which is not the normal bacteria of his skin if they've been having intercourse. So a little bit of an open uterus can lead to any of those things getting inside. Management, so there are options. If somebody has a missed abortion and I'm going to have to treat them in some way, same thing with a incomplete or whatnot, if there's still tissue in there, I can give them 3 options. One is wait and see. Most people will pass this on their own within the first 2 to 4 weeks. That's expectant management. Second, I can medically treat you and try to expedite the process or give you more control over when it will happen, right? Do you want to do it on a Friday where you have the weekend to recover? Then here's a medication to help that happen. Misoprostol makes people have fever and diarrhea and cramping and nausea. So like you typically will give them other meds to help them through that discomfort. Because I tell people all the time, I can't take the emotional pain away. My goal is to make this as physically comfortable as possible. So typically I give them a few narcotics and a few anti-nausea pills. The other thing is going to be surgery. A suction D&C is going to be about essentially 10 to 12 weeks and less. It's called a dilation and evacuation after 12 weeks. In Oklahoma City, there's currently this many people trained to do a D&E. So unfortunately, if you're 16 weeks, you're going to be induced essentially and go through labor because there's nobody here in Oklahoma City that can do a D&E anymore. Because it's just not something people are particularly trained in because, 1, these are rare, right? And 2, politically across the U.S., this is only available in certain places, even if this is an already deceased fetus. Don't forget to assess their RH status, because that's the one part of this workup that will affect a future pregnancy, right? You don't want to make them have antibodies that may cause anemia or problems in a second pregnancy, hence the all caps. Recurrent pregnancy loss, this just means 3 or more of these, okay? So people will have 1 miscarriage and are like, what do I do now? How do I work this up? And you're like, you're just normal. You're a woman. It's 40%. Technically 2 even doesn't buy you a workup. It should be 3 or more losses before you get a workup. Again, it has to be a clinically recognized pregnancy. I literally had a 22-year-old come in and tell me it was her 12th pregnancy. She was counting every period that was ever late. And I was like, that's adorable, but no. You've probably not been pregnant 27 times in your 20s or whatever it was. But she would be like, well, this one was 3 days late and then it was heavy. Okay. Welcome to having a uterus. So these are clinically documented. It can't just be, I think I might have one time at band camp been whatever. They exclude ectopics and exclude molars because there's a reason for that, right? Like that's not a recurrent loss, like you had a bad thing happen to you. This can be primary or secondary, meaning primary, they've never had a live birth. It can be secondary, meaning they had a totally normal first pregnancy and now all of a sudden loss, okay? You gotta go looking for a reason. Sometimes you just get lucky the first time. Like I had somebody have really bad thyroid. They have a 7-year-old daughter they've been trying forever. They're finally about 26 weeks in this pregnancy, but they had 4 losses before that. And when we did a workup when I first got her after the 4th miscarriage, we found that she had like thyroid peroxidase antibodies and a TSH that was like 0.06 elevated. But treating that, she's been totally fine. And so you just find random things that you may not expect. And so secondary is definitely a thing. You sometimes just get lucky, even if it's the same partner as the first time. So risk factors, again, you're going to have that previous pregnancy loss stuff, but then you're going to be talking about uterine factors, so an unknown septum, an unknown polyp or fibroid that's taking up, as I like to say, necessary real estate for the pregnancy. Immunologic factors, so things like antiphospholipid antibody syndrome, endocrine factors, thyroid, diabetes, genetic factors, maybe they have their own kind of translocation on some gene that it doesn't matter if you have one copy of, but their husband has it too, and 2 copies make a baby that doesn't survive. And then thrombophilia and like anything that makes your blood clotting abnormal can be a reason for these as well. So anomalies, the uterine factors are present in about 15% of women with recurrent pregnancy loss as opposed to 7% of the normal population. It might impair distension, it might take away blood supply, it might increase inflammation. We don't exactly know why, but it essentially doubles in people with pregnancy loss, so something to go looking for. Typically it's going to be something that's not created there. The one thing that we might man-made make is those adhesions. You may have Asherman's or something if you've had a really aggressive D&C for some other reason previously. All the rest of them, though, are just going to be like naturally occurring processes. Endocrine factors we've talked about a lot, so I'm not going to beat this into the like a dead horse, but the one I haven't brought up so far is hyperprolactinemia. So you can have an elevated prolactin from your pituitary that really messes with your ability to stay pregnant, even if you're still barely able to ovulate each month. So that's another thing you go looking for when you're looking for endocrine factors. The evaluation, it goes without saying always that your first step in any evaluation should be an extensive history and a physical exam. It drives me banana cakes when I get something referred to me and somebody has never looked in a woman's down there area or whatever it is that they're calling it because they're uncomfortable doing an exam. And don't get me wrong, I don't expect everybody to be perfect at it. What I don't expect is to get called to be like, the patient says she doesn't have a uterus, the CT scan says she does. Can someone come do an OBGYN consult? And I'm like, where did you go to medical school? And if they say OU, I say, I know I taught you better, try again. But that's what you don't want to be. Do you know what I mean? Like, nobody's going to expect you to see something rare or weird or whatever, but don't be the person that asks somebody if a person has a uterus. That makes everyone sad. In our particular scenario, extensive GYN menstrual OB histories, not just she had a period one time, you know, like when did it start, has she ever skipped, how many days are they, have they changed, are they regular, are they irregular, all of those things will help you know what to go looking for. And then keep in mind specific risk factors. So history should be tailored per the person to identify other, you know, things that maybe you think are going on there. So some people will say, I'll ask people when I am worried about PCOS, do you feel like you have any issues? And I literally was talking to somebody with a BMI of like 48 and irregular cycles, distinct acne that I could see just looking at her, and dark hairs on her chin. And I said, do you have any signs of excess testosterone, like hairs on your chin, acne, hairs around your areola, dark skin under your armpits? And she looked right at me and said, no. And I was like, okay. But you don't want, do you know what I mean? Like, so that just teaches you, like, I can't assume that every woman in her family doesn't have 30 hairs on their chin that are black. Do you know what I mean? Like, to her, that was just normal. That's the way that she's always been. Whereas I would be really annoyed. Like, I have 2 now, but I'm old and elderly, and I get real mad about those. So 30 would not probably be on my agenda, but people just sometimes don't recognize things about themselves, right? So you have to continue to tailor your questions to make sure you're figuring out what it might be. Useful tests are going to be karyotyping for both partners, uterine assessment, you can do that in a bunch of different ways. Essentially, the easiest way to do it is going to be in some way to distend the uterine cavity so you can see what's in it. Whether that is a sonohistogram, meaning you've put water in the uterus and done an ultrasound, or an HSG where they do dye and then a radiologic x-ray. You can look in it with hysteroscopy. A plain ultrasound may be somewhere to start, but is going to miss a few septums and polyps and things. An MRI is actually really good for reproductive systems, but very expensive and really only useful to clarify things that you're uncertain about. Anticardiolipin antibodies and lupus anticoagulant are going to be very helpful. They're going to tell you about SLE, and they're going to tell you about antiphospholipid antibody syndrome. Thyroid function, prolactin, hemoglobin A1C levels to rule out PCOS and diabetes. These are samples of some of those imaging. So the one on the left that looks like the smiley face of a jack-o'-lantern, that's a sonohistogram. So that black stuff is the water they've put in the uterus, and now they're doing a transvaginal ultrasound. And you can see polyps and fibroids that are pointed out by the arrows. The pink one, the one that looks like normal tissue, that's because there's a camera in someone's uterus and they're doing a hysteroscopy, so we're looking directly at the inside of the uterus. And you can see a bunch of uterine polyps. The one that looks like a kite with like fluffiness out to the side, that's the HSG that I was talking about, where they do the radiologic dye. So you can see it lights up. You can see that your uterine cavity is very kind of triangular in shape, but then you see how thin the tubal lumen actually is. I mean, it's those tiny little lines, and then that's as it's going out the tubes is what you're seeing as the fluff on the sides. And then that thicker part down at the bottom is just vagina. So as they're trying to push dye through, some of it's coming back out, and you're seeing that as well. And then the MRI is the one on the right with those three big giant circles. Those are very large fibroids. In a uterus that's way above. You can see that it's like way above their sacrum. It's somewhere above their pelvis because it's, you know, up in their lumbar spine area. So that's that part of it. Do we need a potty break? Do you want me to keep going? Like, what do you guys want to do? Let's roll. A pregnant lady can hold it a little longer. So placenta infections, there's two vulnerable portals, right? The first is going to be when your cervix is open in any way, that's a vulnerable portal to getting an infected membrane or cervix, okay? I'm sorry, placenta, I don't know why I said cervix. Well, I'm really pregnant and tired, so but it can ascend that way. So when people get gonorrhea, chlamydia, trich, it can go up. Also just normal bacteria. The most common thing that I see is, and this is just sexual hygiene, for the love of God, if you're doing it anally, do not go back and do it vaginally, particularly if you're pregnant. That's why people get E. coli infections in their vagina all of the time and can get E. coli in there. Like, I don't care how you want to have sex, by all means, have fun. Just don't go back and forth. It's bad sexual hygiene, and you would be surprised how many people look at you like, you know. So these are things that I never thought I'd spend my life talking about, and yet here I am. Also, you can get it through like the blood supply, you know, where the placenta is essentially, you know, taking mom's blood and filtering it and making it baby's blood. So that's where you're going to get things like listeriosis and things that people have gotten through food. Chorioamnionitis is just the fancy word for infection of all the chorion and the amnion, right? Those are the two layers of the membrane. It can be symptomatic or it can be silent. So the symptoms it may cause are going to be preterm labor. It can cause a preterm rupture of membranes. It can cause prolonged labor or neonatal infection. And the microbiology is often polymicrobial. Streptococcus is by far your most common, which is why we now test for group B strep or GBS in pregnant women. When we started treating that with antibiotics in known GBS carriers, because it's a normal skin bacteria, we decreased neonatal sepsis rates by 50% in the 1980s. It's huge, and so that's why that's done. These are the other bugs that are common. Diagnosis is clinical, so you absolutely, end of story, have to have a fever. So 38.0, none of this like, oh, my normal body temperature is 96 and 99 is a fever for me, shenanigans, don't care. 100.5, 38.0. My mom is like the worst at that. She was always texting me, can I give your daughter Tylenol? She has a fever. It's 99.1. And I'm like, that's not a fever. But whatever, give her Tylenol. I don't care. Not a battle I'm worth picking anymore, but that is something in medicine you're gonna have to stick to. Like fever is fever is fever, under it and over it is not. So it has to be 38.0, and then they need 2 of the following 4. So either maternal tachycardia, fetal tachycardia, maternal leukocytosis, tenderness on exam, oh yeah, foul odor of, I'm like, there's another one, I don't know what it is. Foul odor of amniotic fluid, or like foul purulent discharge, essentially. And so without, they can have technically 4 of the other 5, and you can really suspect it, but technically until they have a fever, they don't really rule in for chorio. Risk factors are going to be spontaneous labor, because that might be the reason that they're laboring. First-time babies, that's what the nulliparity means, like this is their first pregnancy. The longer their membranes are ruptured and the longer the length of labor, the longer this is. That's why it's very difficult sometimes to have a conversation nowadays, because it's very, very popular to talk about birthing at home and doing everything on your own and naturally waiting for your contractions to start. And don't get me wrong, I am known for being really midwifey and feeling really crunchy. Like I get listed on a bunch of blogs in Oklahoma City and stuff, because I don't care about a lot of things. If you want to labor standing on your head in an eastern facing room with the lights off, and, I mean, like, I just don't care, because that doesn't hurt you, and it doesn't hurt your baby, right? Like, I am a pick your battles person. But if you're going to try to have a baby in a hospital and you don't want an IV, okay, argument, because that's dumb. I can't help you if you try to die. And they're like, well, what if after I bleed, then you try to put it in? I'm like, you don't have any more veins. They've all collapsed. Or little things like vitamin K. People are like, I don't give my kid vaccines. I'm like, well, it's not a vaccine, it's a vitamin, and it keeps your baby from having a stroke. So my goal is for your baby's brain to work, if you're okay with that. Do you know what I mean? Like, you have to pick your arguments. And so GBS is one of those that I pick with people, IVs, those kinds of things. But like, so I don't care if you don't get checked a bunch, but what it doesn't make any sense is if your water breaks and you wait 24 hours, because at the 24-hour mark, your NICU admission rate, your sepsis rate of your infant doubles. And at 36 hours, it triples. And at 48 hours, you're guaranteeing yourself a NICU admission. And so, you know what I mean? Like, this is one of those things that you want to fight for. Meconium state amniotic fluid, because that can be a sign of distress. It can also just be a sign that baby's been in there too long. But it can be a sign of distress, so that's why we pay attention to it. If there are internal monitors, that gives the anitis, right, for bacteria to go up, and sometimes you have to use them, but you don't want to just willy-nilly put things, you know, that are going from the outside world all the way to baby. Presence of genital tract pathogens, that's why in Oklahoma you need to check gonorrhea, chlamydia on every pregnant woman, doesn't matter if they're married, doesn't matter if they only have one sexual partner. Our rates are stupid high, just like they are for all things that are bad. Obesity, smoking, and we're really low on things that are good, like education and, you know, preventing teen pregnancy. Though we are getting much better in that, by the way. I think we dropped to 3rd. That's right. Woo. Anyway, and then multiple vaginal examinations. So just things to pay attention to. Treatment is antibiotics, and you just need to get that baby out of there. This is going to sound horrible, and you can all be like, oh, get sick. But until you deliver the abscess or the infection, it's not going to get better, right? And until that baby and the placenta and the water and the membranes, like whatever it is that's infected gets out, it's just going to stew until it's out. So an infected baby that's in there 20 more hours is not ideal. If you think you can get a baby out in 6 hours, that's worth trying. Vaginal bleeding in pregnancy and the postpartum. So let there be blood, that's what we're going to talk about now. It's a common event in all stages of pregnancy. We already talked about first trimester, right? So now we're going to talk about later. It's virtually always maternal, not fetal, and it results in a disruption of the decidual blood vessels, aka most likely between the placenta and the uterus. Occasionally it can also be because of discrete cervical or vaginal lesions. Like I had a pregnant person come in to an outside hospital where the hospitalist called me and literally said, like, do you think your patient is hooking? And I was like, I'm sorry, what now? I thought you said she had vaginal bleeding. And they were like, yeah, but she has a vaginal laceration. She's wearing more makeup than anybody I've ever seen. You know what I mean? They were just kind of making an assumption. And I was like, well, I'll talk to her about, is she safe at home? Does she have weird, you know what I mean? Like, is anything going on when I see her next? So you can't just assume that just because they're pregnant, they don't have any risks. This is the highest time in a woman's life that they are most likely to undergo spousal abuse and rape. And so you just can't forget about domestic violence in these scenarios, okay? That's a really sad stat of pregnancy, but the truth nationwide. Like we talked about with first trimester bleeding, this is just kind of an overview slide, 20 to 40% of women. And we talked about most of those reasons. The things that I did not bring up are technically people can have implantation spotting, so some spotting when the pregnancy implants about 2 weeks after their missed period. And they can also have the same pathology that everybody else does, right? Do they have cervical cancer? Do they have a uterus problem? You know, so you just can't forget about the other things. Second and third trimester bleeding is much less common. In the third trimester or the second trimester, you're going to have bloody show associated with labor, or if it's early in the second trimester, a thing called cervical insufficiency, right? Their cervix just opens without pain. They don't feel like they're in labor, but all of a sudden they're 4 to 5 centimeters. You can have placenta previa, which is the fancy word for the placenta being over the cervical os. That can happen in a lot of different ways. There's complete previas, so complete coverage of the cervical os. There are partial previas, meaning it covers part of it from one side, front, back, right, left, whatever. You can have low-lying placentas, meaning within the first 2 centimeters of the uterine wall. So from the internal os to the uterine wall, typically 2 centimeters is the magic number. Some people will use as low as 1.5, some people will use as high as 2.5, so we typically talk about 2. And so all of those matter because baby can't come through its own placenta, right? It's essentially like literally stabbing itself as it's being born. Yes?
How long does the placenta grow?
In
like at what point?
size
Yeah,
or
so
like where it moves? Because those are 2 different questions.
both. Like when do you know that you have placenta previa to the point where you can't deliver?
So most of the time, it's going to be diagnosed early. So typically in your anatomy ultrasound between 16 and 20 weeks. That doesn't mean it's permanent. Unless, I mean, if it's a complete previa, like, well, bam, here's my cervix, and there's just like a placenta like, hello, that's probably not going to move. But when you're talking about partial previas or even the low-lying is very likely to resolve. Partial previas are not as likely to resolve. But if you think about it, it is not that the placenta grows legs and like walks up the uterus, which is I think how people imagine it. I'm a really horrible artist, so bear with me. It always ends up looking like a longhorn. But, you know, tube, ovary, you've got your uterus, right? So cervix, this is your opening into the vagina. This is the opening into the uterus where your cute little baby hangs out, right? Sick people. So your placenta is going to be somewhere. It may be fundal, it may be anterior, it may be posterior, but let's, you know, for drawing's sake, say that it's on the side. So if it comes right here and there's like 5 millimeters between the opening and the placenta, what they're going to look at, and this is at 18 to 20 weeks, the placenta itself doesn't move. What happens is this part of the uterus, known as the lower uterine segment, the non-contractile portion of your uterus, doesn't develop until 26 to 28 weeks. So then, at some point, what your uterus actually looks like is you've got this big contractile portion. You've still got your cervix here. I want to struggle less with this chalk. Let's get rid of these. You've got your cervix here. The placenta is still where it was before, right? But now you've got this ballooned out lower uterine segment that's like a water balloon. It's non-contractile. So this is what we're aiming for when you talk about C-sections being in the lower uterine segment or the non-contractile portion, because it's less likely to rupture later because it's not contracting. Whereas if you put the incision this way, you're into this contractile portion of the uterus. So most of the time you'll have that 18 to 20 week ultrasound, and your first follow-up will be at 28 weeks because we think you should have some lower uterine segment developed by that point. If it's not completely resolved but improved, they'll scan you again at 34 to 36 weeks to delineate for sure, did you make the 2 centimeter cutoff, did you not?
Okay, thank you.
No, it's a good question. And I talk about it a lot, if you can't tell, because people are like, I don't understand, why won't it just move? Like, I'm like, well, it doesn't grow legs. Your uterus changes, not really the placenta. So you can also have abruption of the placenta. So that is typically, previa bleeding is typically painless. So previa, painless. And abruption is usually very painful. So it's essentially blood in between the placenta here in the uterus. And so if you think about it, it's essentially blood bleeding into here, causing contractions and irritability of the muscle. So that's why it's different as opposed to if your placenta is here and it starts bleeding and it just does this, that's not going to be painful, right? Whereas the one on the side is going to be painful. You can have a uterine rupture. Obviously that is much more likely to happen in someone that has had a uterine surgery, but it is not. It has definitely been reported multiple times of spontaneous uterine rupture, though that doesn't happen very often. And then you can have vasoprevia, which again would be instead of the placenta being across the os, say the placenta comes in like this, baby's over here, and the umbilical cord, for whatever reason, did this. And so as it implants into the uterus, you have these, like when you have a placenta, if you see it, it looks like a spider web almost of vessels, and sometimes it goes past the meat into the membrane portion. And if your cervix is here, that's going to bleed like straight through to the vagina. This is stupid scary because babies, you can be in the hospital, my OR could be where the bathrooms are, and your kid might die before I can get you there. Like that's how no bueno this is. So people like live in the hospital from 30 weeks on, and we still have no guarantee that we'll be able to save either one of them. That's like a 2 to 5 minute dissanguination. So if you were going to pick one, I wouldn't pick that one. You can also have the same uterine pathology in the 3rd trimester. I have diagnosed a cervix cancer and a transfer at 30 weeks, and I went in to do an exam, and there's just this huge fungating mass. And so you just can't forget the other stuff that isn't pregnancy related, and I know I've said that a couple of times. Again, evaluation would be a complete history and fully characterize their symptoms. And if I teach you one thing about evaluation, it is do not put your hands in their vagina if you don't know where their placenta is. So if you have an ultrasound and it tells you that they do not have a previa, sure, check them. See if they're laboring, if you feel comfortable doing that before transfer. If you are not 1 bajillion% certain of where their placenta is, don't stick your hands in there, because if you put a finger-sized hole through the placenta, things are going to get a lot worse before they get better. Yeah, that's why I'm yelling at you in this slide. So prognosis and management is so dependent. How pregnant are they? How bad are they bleeding? Are you going to have to deliver them that day? Are you going to be able to wait because it's not affecting the status of mom or baby? Gestational age and the cause and the severity, like all of those things completely change what you do. So what I do for a 24-weeker and how bad I push how far I can go without delivering them is super different than a 37-weeker, right? Like that 37-weeker kind of blinks at me wrong, and I'm like, yeah, we'll just have a baby at 37 weeks. That 24-weeker kind of bleeds, and I'm like, God, I'd like to get you to 28 weeks because your morbidity goes down by 50%. Whereas if I deliver you at 24 weeks, I very well may be delivering somebody that's going to live in a wheelchair for the rest of their life. So you just have to be aware of those things because it changes what you do and how bad you push. Postpartum hemorrhage is the other version of bleeding. There has been a huge movement in Oklahoma over the last 5 years to standardize practices across the state, particularly in rural areas, because this is a true obstetric emergency. It's one of the leading causes of morbidity and mortality in women, particularly morbidity, so like transfusions, elongated hospital stays, wound infections, etc., etc. And so there is like that was one of the state's like big pushes along with like the LARC incentive for teenagers. It has made a significant difference. and it's the leading cause of admission to an ICU. I mean, it's a big thing. So the definition is very depending on what kind of delivery you've had. It happens in 1 to 5% of deliveries when it's your first time to have it happen. It happens if you've had a postpartum hemorrhage before, your risk is at least 10%, as high as 33% in some studies. The definition is clinical, but it essentially is a blood loss. It's like a number of blood loss for depending on the way you deliver. You would obviously anticipate a vaginal delivery to have less bleeding than a C-section, because in a C-section I'm cutting through muscle, right? So 500 cc's for a vaginal delivery, 1,000 for a C-section. A C-hyst, otherwise known as I had to take your uterus to stop bleeding, you would not call it a hemorrhage until it was 1,500 cc's. The other thing is postpartum, you can technically diagnose that they probably had a hemorrhage by using the 10% decline in postpartum hemoglobin from their antepartum levels. But let's be clear, that clinically means nothing to me. Particularly, let's be very clear, if I'm gonna labor at home for 12 hours and be all cranky and huffy and puffy and barking at my husband, I'm probably not hydrating myself, and I'm probably gonna come in hemoconcentrated. So then if I lose like next to nothing at my delivery and somebody's like, oh, your hemoglobin dropped 2 points, I'm like, no it didn't. You gave me 3 liters of fluid, particularly so I can get that epidural I really wanted, you know? And so it's just not clinically helpful, but part of the definition, therefore, on your slide. This is a slide so that you guys remember that same thing I talked about at first. People do well until they do real bad, right? So for people to have significant blood pressure change, they've probably lost 25 to 35% of their blood volume. That's kind of like, excuse my French, but oh shit levels, right? You're like, this is no bueno. So these people are the ones that are not making urine anymore. They're getting pale, they're not doing well. And by the time you get to 45%, these people are collapsing. They're air hungry, they need to be intubated, they're lethargic, they're plus or minus responsive. And so these are things that, this is why it's important to recognize early, because if you're going based just on symptoms, you're behind the 8 ball already, right? So if you're not treating the blood volume loss that you see, you're treating the patient that's looking at you, you're probably behind where you think you are. Because they're not gonna get many symptoms before they get real bad. The one thing that is the most common thing you should be checking is pulse, because tachycardia is gonna happen way before their blood pressure sucks. Okay, so you always wanna remember that if their pulse was 90 before, like if their pulse is 88 to 90, you can pretty much tell yourself like they're doing okay. When their pulse is 100 to 110 postpartum, you're like, okay, I should be paying attention, but that can be normal for a pregnant or postpartum woman, right? When you're 120 or more, something's happening. And if you look over and people are 140, 150, like you're behind the 8 ball, you need to go and you need to treat and you need to be labbing it up and going, 2 more IVs and fluids at that point. Etiologies, the most common thing is going to be uterine bleeding from atony. So those 4 major causes, atony is by far the most common. AKA that muscle of the uterus is tired. It just says, I'm done, I can't do this anymore, no more contracting. But what you want it to do is contract to cut off all those spiral arteries, right? If it's just floppy, all those spiral arteries are just bleeding like they were feeding a placenta, except there's no placenta there anymore. So atony is a big cause. It can be trauma, so that can be from the birth itself. Did they have a uterine rupture? Do they have a cervical laceration? Do they have a really bad vaginal laceration? Like, where are you getting this blood from? So a thorough exam is important. Coagulation defects that are unknown can materialize here, but they're gonna be the rare ones, right? Because most people are not gonna make it to a reproductive, now granted, if you're delivering a 15-year-old, maybe you're gonna find something. But if you're delivering me, like I should have had some like other episode of something, right? A hemorrhage from a period, bad bleeding during dental work, something that tells you I have a coagulation defect before the first birth. So though it is listed, it's always going to be more rare. That's the rarest of the 4. Retained products of conception, so a tiny piece of membrane or placenta is stuck in there, and so blood supply is still going through that, as opposed to all the rest of the uterus that is contracted down. Those are going to be your most 4 common reasons for a hemorrhage. Acne is 1 in 20 births. It's 80% of all postpartum hemorrhages. So when I say it's most common, like, I mean, it is most common. So people that are going to have bigger reasons to have this are going to be, one of the big things is going to be over-distension. So like unlucky humans like myself that apparently have 9 to 10 pound babies, like my uterus is bigger than my best friend who had a 6'2" baby. But you know, I'm a giant, so I have giant children. And that's just kind of the way it goes. But think about if I had 2 of them in there, then I'm really over-distended, right? So multiple births. People that have twins or triplets or whatever, super higher risk for hemorrhage and acne. Infection, right? We talked about how your muscle can't contract. Same thing here. They're much more likely to have a hemorrhage if they had IAI or chorio, whatever you want to call it, during the delivery process. A prolonged labor. Some of us get to labor a long time. I went 36 hours my first kid, which, by the way, not fun, in case you're curious. But I had all kinds of setups, do you know what I mean, for badness, and luckily didn't have any, but that doesn't mean it won't happen the second time. So you just have to be aware of all of those things. Drugs that cause acne, so, or like relax muscle, so we use magnesium a lot, right, for preeclampsia. That relaxes muscle, so that's going to make you more likely to have a hemorrhage. And then of course if your uterus doesn't come back down correctly, you're going to have a problem. Complications can be the shock and stuff that we've already talked about, and then this is that thing that you never see in the real world, but get a stupid exam question on all the time, is Sheehan syndrome. Oh, they came back and they don't ever have a period ever again, and their blood pressure's low, and now they can't make milk, and I don't understand why. Well, they have Sheehan's, if that's what the question stem says. So I would just mark this as one of those random things you kind of want to know before an exam, but we'll probably never see in the real world. And then I've already kind of talked about this, but this is just, you treat it like any other trauma or hemorrhage. Restore labs, fluids, maintain adequate tissue oxygenation, and avoid coagulopathy, which means, unlike in the olden days where we gave people 8 units of blood before we gave them other things, military data tells us this should really be a 1-to-1 or 2-to-1 thing. If you're giving blood, you should be giving cryo. And that is not something we knew 20 years ago. Hypertensive disorders. So this is a sliding scale. These are the 4 main types, and I'm trying to hurry because I know it's almost 4 already. Gestational hypertension, chronic hypertension, preeclampsia, and then chronic hypertension with superimposed preeclampsia. It has a 5 to 10% incidence, so like at OU, when I ask med students that, how many people are preeclamptic or have a hypertensive disorder, they will say 50% sometimes if they haven't read the book chapter yet, because that's how much they see of it there from transfers. Whereas I've been at Lakeside for 10 months and I've magged a whopping 1 person. I hadn't gone a shift at OU without magging somebody, so I was like, this is crazy. Which is why I, again, think I'm a little more used to this stuff. We don't know the cause. There is literally a place in Chicago where there's like all these, in one of their obstetrics hospitals, where there's all these like places for plaques for people that solve preterm labor, preeclampsia, and a bunch of other junk. Well, they're all still blank. We don't even know what causes preeclampsia, much less how to fix it. So there are many different theories. A lot of them involve placental and fetal factors. A lot of them involve maternal factors. There's actually a study out there called the evil sperm, where you are literally more, it has been proven that you are more likely to have preeclampsia if your husband's mother had preeclampsia than if your own mother had preeclampsia. So there is something to do with that. The longer you've been exposed to the same partner, the less likely it is. If you get divorced and have a new husband, your risk is baseline again, as opposed to lower because you had a baby. Like, so if I've had a baby without preeclampsia, I probably won't have preeclampsia in this pregnancy. But if I ditch my husband and get a new one, I'm just as likely to get it as I was the first time. It's very intriguing. Like, we don't understand any of that pathophys. But there's circulating angiogenic factors that we think play a role, and that's the maternal part, which essentially causes endothelial cell dysfunction in the vessels of the placenta. And then there are, of course, the paternal factors that I just talked about, and then there's environmental factors like the amount of calcium in your diet and those kinds of things. Preeclampsia, so let's stop here to say, I'm going to call things mild preeclampsia and severe preeclampsia, because that's what your book says. Typically, the books are about 8 to 10 years behind whatever like new data is. We don't actually refer to it that way anymore. It's just preeclampsia, and then we say with or without severe features. In the book world, it's still based on blood pressures and proteinuria. There are levels of proteinuria that make you mild or severe in the book world. In the real world, it is now just, if you have proteinuria, it makes you preeclamptic, I don't care how much. It can be 5 grams, it can be 1,000,000 grams, it can be 300 milligrams, okay? So these are the numbers you would need to know from like a book answer and typically testing at this point. I will change this slide when it changes for you guys, because my goal is not to confuse you when you're looking back, which is why I don't write out all the stuff that I'm saying. I just want you to understand that it has changed. So 140 over 90, anything above that is mild. 160 over 110 is severe. And then it's 300 milligrams and 5,000 milligrams or 5 grams in a 24-hour urine specimen of urine that would rule you in from a proteinuria standpoint. Gestational hypertension would be elevated blood pressures without any reason to think that it's preeclampsia. So no proteinuria or the lab abnormalities that we're going to talk about on the next page. Severe preeclampsia can also be ruled in by oliguria, so less than 500 cc's in 24 hours. It can also be with cerebral or visual disturbances, so that's why we ask all people that are pregnant with any blood pressure, do you have any issues, like any problems with your vision, have any right upper quadrant pain, or epigastric pain, and are you having any headache? Because you can have press or like increased pressure in your brain, which can cause eclampsia, which means a seizure, okay? So if you're preeclamptic, you have this process. If you are eclamptic, you have gone on to have a seizure. And then blindness or scotomata are the visual disturbances that we care about. I don't care about fuzzies, wavies, wigglies, shiny things, blurries, none of that stuff. Scotomata is a fancy word for you're looking at my face and part of it is gone with a black spot, versus like literal areas of blindness. And it usually goes peripheral to central because the pressure is at the back of your head. Pulmonary edema, epigastric or right upper quadrant pain can be associated with increased pressure in the liver. You can, in rare cases, get a liver capsule rupture or a Gleason capsule rupture, which can cause hemorrhage and significant problem. Impaired liver function, so elevated liver enzymes. Thrombocytopenia has to be less than 100, remember, not just less like non-normal in your lab, because most labs are somewhere between 120 and 140 being normal. So if it flags you at 136, that's not preeclampsia, it's under 100. And then fetal growth restriction is used in this, but again, a lot of these things aren't used in the new one. So growth restriction is taken off completely, proteinuria is taken off completely. So there have just been some changes with data over time. HELP syndrome is like the next step up from severe preeclampsia, and it obviously stands for hemolysis, elevated liver enzymes or LFTs, and then low platelets. Again, it's not just when it barely flags you. Low platelets need to be less than 100, LFTs need to be 2 times normal, and then the hemolysis needs to be an LDH greater than 600. So this is a severe subset of preeclampsia. It means it's so bad you now have lab abnormalities. These people can go into DIC pretty quickly from the low platelets and the liver enzymes and the coagulopathy defects. So preeclampsia risk factors, again, I'm not going to read them to you, but remember, smoking is not on there. And the more placenta you have to create badness, the more likely you are to have a bad thing. So multiple babies, big placentas, more hormones that can create a problem. Diagnosis and evaluation, it is a spectrum of disease. Please have a high clinical suspicion of this being a problem. No pregnant woman should ever have an elevated blood pressure that is not reported to their obstetrician. I had a nurse that was my patient that was admitted to the neurology service at an outside hospital for migraines, who ran in the 150s for the 4 days of admission. That was never told to me. She came back to her visit with me 7 days later with a dead baby. So that's what I mean by, like, this is not a, hey, I'll just send them a note. This is a, you call a physician, you tell them you have them, you tell them their blood pressure is elevated. And it may be nothing, but you may save a kid, which is a big deal, okay? Laboratory studies, those are the ones listed that I just talked about. Like literally I have goosebumps talking about it with you guys. Anyway. Antepartum fetal surveillance, these people get more surveillance. They get admitted to the hospital for a while while their blood pressures are originally high to see how bad is it going to be. They get weekly ultrasounds and they get weekly or twice weekly monitoring of their baby because these people have a high risk of bad outcome. Because of that, management is highly variable. When I was a resident, which I know seems like 100 years ago, but really wasn't, I only graduated med school 10 years ago. So we were talking about 6 years ago, we admitted every preeclamptic and they all lived in-house, whether they were mild, severe, they just lived there like rocks on the antepartum service. Now only severe people are admitted permanently. Mild people are managed as an outpatient, which I will freely admit gives me a little heartburn, but statistically makes sense. So things will change in your career in a very short period of time, which is why it's always going to be important to continue to read and stay up to date. You want to assess maternal status, look for that end organs damage, assess the fetal status, and then control blood pressure. Do not tank their blood pressure because that baby will be pissed. Because they're only getting, like if it is taking a lot of pressure to get blood flow across the placenta and all of a sudden you take it all away and you've normalized mom's blood pressure, that baby's like, where's all my blood? And it is mad. So you want to decrease but slowly, and you want to go for normal but slowly. So a 10% decrease at first is all you really want. And then delivery timing is dependent on the severity of the disease. So severe people get delivered at 34 weeks because at that point babies do better out than in, even if they're going to be in the NICU for a little bit. Mild people get delivered at 37 weeks because there's very little to gain after you turn term. And anybody with an elevated blood pressure, it used to be gestational hypertensives get delivered at 39 weeks. The new giant 45-page paper from the U.S. Preventative Task Force says 37 to 39. So we deliver these people a lot earlier than we used to because we just realized there's just not the same benefit. These are medications that are safe to use in pregnancy. It is a list, you need to know them. I will tell you, almost everyone in the world uses nifedipine now as first line, if you wanted to circle that and know. Alpha-methyl-dopa, or Aldamet, is old school. It was the only med that we had that was safe at first. To be honest, in low doses, I would just as soon rather you give my patient a lollipop. It just, like, they might as well lick the pill instead of take it. It just doesn't work very well. And we have data that says that. But when you're using it, we do use it still as second and third line agents to add to another agent. Seizure prophylaxis is magnesium. It's standard of care. It is IV only. Oral magnesium does not help. It can be potentially very toxic. It can cause respiratory distress and cardiopulmonary arrest. So I don't say that so that you won't use it. I say that so that you know, just like literally we had a transfer come to OU who was put on magnesium. She didn't want to pay for an ambulance, so she drove 3 hours from the Panhandle with mag on a coat hanger in her car, and they were like, well, her daughter's real smart, she'll be fine. And I was like losing my mind until she got there. Because if their levels are over 12, like their magnesium level, the goal is 4.8 to 8.4. When you start getting in that over like 12 or 14 range, they literally can just stop breathing. And so open bolusing that is scary. So you want to give it, it's very important, but you want to be careful and monitor those people while you're doing it. If somebody cannot have magnesium because of a toxic event, that woman came back later and said she was allergic to magnesium, which I whispered to my residents to not tell her bones, but then thought, I don't blame the person, right? Like she thinks she is because she tried to die from it because somebody just ran it wide open. But if they do have a problem or had an adverse event, phenytoin is the alternative. You obviously don't want to give that willy-nilly in pregnancy. It is one of those meds that you do not give like throughout the whole pregnancy, but in a short period of time like this is safe for a neonate. Eclampsia, so if somebody's had a seizure, you treat it like any other seizure. You cannot resuscitate baby until you resuscitate mom. So resuscitate mom. The ABCs, airway, breathing, cardiovascular, call for help. They need MAG and they need it 5 minutes ago because that is the most likely way that you're going to decrease their seizure threshold. If you do not have IV available to you in a bolus, pretty much anywhere you work should have a crash cart, which has 5 mg ampules of magnesium. Give them 1 in each butt cheek, and call 911 and get them somewhere that has it. Persistent convulsions, you're going to use other seizure medications, diazepam, lorazepam, but obviously just get them somewhere that, you know, can treat this and get them in an ambulance. And then delivery is the goal. The only treatment for preeclampsia at this stage is delivery. If that placenta is in there, they will continue to be preeclamptic until it is gone. Diabetes in pregnancy. The introduction is essentially, you want to think about it these days as type 1 and type 2. They either, you know, are type 1 or type 2, but there is still a White's classification for gestational diabetes, which essentially grades it A, B, C, D, and then worse. Obviously, you'd rather be an A than a B or a C or a D. The longer you've had it, or the worse your side effects are from it, is what category is how you fall into those categories. Pregnancy by itself is a state of insulin resistance. Your placenta makes a thing called human placental lactinogen, which HPL or HCS, depending on whatever you want to call it, plays a major role in maternal insulin resistance. So the more of that your placenta makes, the more of that you are going to have, and the more likely you are to be insulin resistant or get gestational diabetes. So the more placenta you have, again, the worse your luck. So twin moms and triplet moms much more likely to be gestational diabetic than a singleton mom. Also, it's just genetics from a risk factor standpoint. So lots of family history or obesity or ethnicity all play a role. Though let's be clear, my best friend is a cardiologist, and she literally weighs as much as one of my legs, and that girl always fails her diabetes screen, and my fluffy butt never fails. And it is just genes. Do you know what I mean? Like, those are just like, that poor girl, it's not her fault, and it's definitely not because I'm doing anything right. Overt diabetes is going to be a fasting plasma glucose more than 125, or a hemoglobin A1C greater than 6.4 or 6.7, depending on the study that you read. Essentially just realize that over 6.4 is abnormal, and you should get those people to a high-risk obstetrician. Also, a random glucose greater than 199. So if you give people a glucose screen and their value is 220, like, they don't even have to do the confirmatory test. They just get to have diabetes and start treating it. So screen positive with a 1-hour glucose screen, that is between 24 and 28 weeks in every pregnancy. No matter your ethnicity, your weight, your age, anything, because it's just so common, and sometimes it's just not your fault. Like Dr. Tindera, she just doesn't have a chance. 135 is what's used most places. There are actually 2 scales, one saying using 130, one saying using 140. So most physicians actually just split the difference and use the middle. You then confirm it with a 3-hour glucose, so they get a fasting, then they get a 100-gram load, and get their blood taken at 1, 2, and 3 hours to see if they can clear it appropriately. And multiple risk factors exist. Like I said, ethnicity, weight are going to be your primary ones. Complication of diabetes: if you have diabetes, you're more likely to have preeclampsia. If you have preeclampsia, you're more likely to have diabetes. That's a bit of a chicken and an egg scenario there. Hydramnios of some kind. The reason we don't talk about it being oligo or poly, oligo meaning not enough fluid, right? Oligohydramnios, because brittle type 1 diabetics, they have vasculopathies, right? That's why they get all the issues that they get. Well, what's the placenta? It's a big vasculopathy. So it doesn't work as well. They have small babies and low fluid. A gestational diabetic who's like, look at me swimming in all the glucose, they get big, and they get that polydipsia, polyuria, so then they get lots of fluid and they have polyhydramnios. So that's why with diabetes you can get these very big babies and very small babies and very big fluids and very small fluids. It really depends on the type of diabetes that they have. They are much more likely to have a birth trauma. They are much more likely to have a shoulder dystocia. They're much more likely to have an operative delivery, perinatal mortality or a stillbirth, and then they will have neonatal respiratory or metabolic complications. Diabetic babies just really struggle with that transition, and a lot of times need oxygen even at like 39 weeks, when babies that didn't have that sugar control issue don't. They have sugar control issues, but because of that sugar control, if they, like, if you think about it, their pancreas works, right? So their pancreas is just pumping out insulin like it's its job, and then all of a sudden their sweet tea that they're like swimming around in is gone. And then they're still pumping out that insulin. So all of a sudden they become really hypoglycemic. Because they've lived in those high sugar environments, they become polycythemic, or lots of red blood cells, which causes higher rates of jaundice. They have lower rates of magnesium and calcium, and so their electrolytes can be off. There's just lots of things that can kind of happen. So you're gonna have to prepare these moms that they're just more likely to need a little help. Now, 2 weeks later, you're not gonna know the difference between a diabetic baby and a non-diabetic most of the time. But in those first few days, it can be a big difference. The macrosomia and things can lead to shoulder dystocia, which I want to make sure you guys understand is like a true emergency, because their head comes out, their shoulders don't, they're losing oxygen to the brain. These people are much more likely to have cerebral palsy, they're much more likely to have permanent nerve palsies or injuries to one of those shoulders. And it's not because they're necessarily that big, it's where they put on their weight. They're like these linebackers with like these giant shoulders and wide hips, as opposed to kind of those long lanky babies that you sometimes see without all the cute little rolls. And don't get me wrong, like babies with rolls are adorable, and I'm always annoyed that my babies are like 47 inches long and don't have any. But also, really truthfully, those rolls can be a bad thing and make it harder to get those babies out. Maternal issues are going to be the same issues as diabetes, but I did want to list a slide where you can kind of see the difference between what happens with both of them. And the worse their diabetes, the more likely they are to have these things. If they can control their A1C and keep it below 7, they're going to be much, much better. But like my lady that had a hemoglobin A1C of 10.7, her baby has a huge cardiac defect, which is probably 100% because of that A1C. Cardiac and neurologic, so like spinal defects are really common. General management, nutrition therapy, exercise. People are like, but I'm pregnant. I'm like, good for you. Let's go swim or walk or elliptical or whatever. Glucose monitoring between 6 to 7 is your pre-pregnancy goal. So people that come to you and are like, I want to get pregnant. My last hemoglobin A1C was so much better. It was 8.5. You still want to talk to them about the fact that that's putting them and their baby at a lot of risk. Miscarriage and those cardiac and renal and neuro defects. They all get more testing because they're all at a higher risk for things like stillbirth, so more ultrasounds for growth, more ultrasounds at the end to make sure that they're still happy in there and getting enough blood supply, and the timing of their delivery changes depending on the ability of them to control their sugar. If they're really well controlled, they can go to 39 weeks. If they have crappy control, they get delivered at 37 to 38 weeks. So it just kind of depends again on severity. Again, these are the ways that you can control glycemia. We used to use a ton of hypoglycemics oral, but there was a big study that came out last year that actually says even when their A1C is controlled with an oral hypoglycemic, the outcomes are better in insulin. And so people have taken away a lot of the glidazide and glyburide that we were using before. Some people, particularly for patients that refuse insulin, will still use metformin. But at this point, most of the time, if they're not like almost due and they're failing their dietary maintenance, most people will get insulin at this stage. Again, it's not likely permanent for a lot of these gestational ones, but the outcomes are better. Postpartum, they all need follow-up. So even if you were diagnosed in your pregnancy, you need to confirm that it was actually a pregnancy problem and not a you problem. So 6 to 12 weeks postpartum, you'll get a 2-hour GTT to rule out undiagnosed diabetes. And pre-gestational diabetics should go back to whoever was managing their pump or whatever before. Now, I will always freely admit to you that I would, particularly in a pump-dependent brittle diabetic, I would always rather their sugar be slightly high than too low. People that are too low are found down, they have rhabdo, they die. So a blood sugar of 40 is much more problematic to me than a blood sugar of 180. Now don't get me wrong, I don't want them always in the 180s, but I would much rather that than them be too low. Preterm labor and Pcos, they're kind of together, and we're getting really close to the end. I think there's this and depression. So preterm birth is by far the leading cause of morbidity and mortality in infants. The rate is 12.8. We've marched to a lot of dimes, but it is always 12%. That has changed nothing. The relationship between morbidity and mortality is nonlinear with gestational age. It is very logarithmic. So 24 weeks is exceptionally different than 28 weeks. 28 weeks is very different than 32 weeks, so on and so forth, okay? So you can kind of see this logarithmic scale on the left. So preterm by definition is less than 37 weeks. There's now all these really specific definitions, right, about like early term, term, late term, and post-term, which I don't think you guys need to know, but those are between 37 and 42 weeks. So early term is 37 to 38, 39 is now term, 40 is late term. It's not until you're 41 or 42 weeks that you get to be post-dates nowadays. Risk factors can be stress, and I don't mean just like my husband is really stressing me out, I mean like big stressful life events. Occupational fatigue, which makes me laugh every time. Excessive or impaired uterine distension, so again, you know, the bigger the baby, the more the babies, etc. Most twins are born at 36 weeks, that's the average. And that's because their uterus thinks they're 45 weeks, right, at that point. Cervical factors play a role, infection, placental pathology, and then any fetal anomaly sometimes disrupts the pathway, the hypopituitary ovarian axis that like jump starts labor. Diagnosis in a sentence, painful uterine contractions that lead to cervical dilation. So what I mean by that is all of these people that come in complaining of contractions but don't do jack diddly squat to their cervix do not have preterm labor. Now they have preterm contractions, and that doesn't mean that it's nice, and it doesn't mean that it doesn't suck, but they are not in labor. So these people that are like, I was on bed rest for the last 10 weeks of my pregnancy and then I had to be induced from closed at 40 weeks, you're like, that is not preterm labor. That's just contractions, and it does suck, don't get me wrong, but it's not, by definition, labor. Evaluation, history, physical exam, which would include a cervical exam, determination of gestational age, and then things that you should be doing to make sure you know the answers. So anybody that's preterm may not have their GBS done, so you would need to do that, and then they should all be rechecked for any infection on their cervix, like gonorrhea, chlamydia. Most places will typically do a drug screen to rule that out as a reason for preterm labor, and then it used to be very, very popular to do a fetal fibronectin. Most places do not do them now, but it's still listed in a lot of your books. Fetal fibronectin was a test that was pretty good at having a negative predictive value of about 98%, but its positive predictive value of preterm labor was like less than 20%. And so it's just not used very much anymore. But a cervical length on ultrasound is very helpful. If your cervix is more than 2.5 centimeters in length, the likelihood that you'll deliver in the next 2 weeks is less than 10%. Management, the big thing, particularly if you're going to do primary care or work in an ER or do something where you might actually have to transfer somebody one day, is for the love of God, give them a dose of steroids even if you're not sure that they're in labor. If they are less than 36 weeks, they should get steroids, because every single hour that that baby has steroids in their system makes dramatic difference in their NICU outcome. So you may think it's not a big deal for them to get it until they get to that other place, but if you're talking about 4 or 5 hours, that's distinct. So typically we use betamethasone or dexamethasone, IM. The reason that is because that's what crosses the placenta. Prednisone or something oral does not. And you're never going to keep them for 48 hours to give them the multiple doses. You're just going to give the one-time dose and ship them, typically. Appropriate antibiotics should be given. If you do not know their GBS status, you would act like they have it. So ampicillin or penicillin in a standard of care. If you can, if they're allergic and you can give them Ancef, great. If they are unknown and they're like deathly allergic to that, where you don't want to give them a cephalosporin. In some places in the United States, the next choice would be clindamycin or erythromycin. Our rates of resistance in Oklahoma are greater than 50%, so your only other option is Vanc.
I have a question, sorry.
Yeah.
If you had GBS sepsis as a baby, are you at greater risk factor for your future children?
No, so it's only if you had a child that had GBS sepsis.
Okay.
So at any other, like if you had a child, so these are the, so if they're unknown, you would treat anybody that is preterm. If they're a previous pregnancy, had a baby with GBS sepsis, if they have been ruptured more than 18 hours, you just are like, ugh, they probably have something, treat it. And if they had GBS in any urine sample in the entirety of their pregnancy. If they are term with no risk factor and they come in 38 weeks and laboring, if they just skipped that visit, you wouldn't treat it at that point. Though I jokingly say all the time, like I didn't even want to swab myself in pregnancy, I just wanted to be treated. And they were like, no, that's dumb, we're following the rules. I'm like, little penicillin never hurt anybody. She's like, actually, I'm like, oh, shut up, I'm not allergic. But that would be the reason. Whereas if you had it yourself, it doesn't really matter because so many years down the road, you will have it somewhere on your skin. It only matters where it is on your skin at the time of delivery. So if it's not in the vulva or vagina, it doesn't matter. Tocolytic drugs for up to 48 hours to delay, particularly to try to get those steroids on board, and then appropriate antibiotics in the cases of like positive cultures for other things. So of note, like I said, the new recommendation for late preterm steroids is up to 36 weeks, but your test answer is 24 to 34. But we now give steroids up to 36 weeks unless they're diabetic or their water is broken, but there are reasons not to. So beta and DEXA, one of the other things that people like that sometimes comes up is like, what does it do for babies? So it decreases their rates of all the bad stuff that you hear about. So IVH, neck, retinopathy, and respiratory distress, obviously, lungs. That's the main reason to do it. Tocolytics that can be used, magnesium sulfate, also now used for what's called neuroprotection. There was a big study that said it decreases the rates of cerebral palsy in surviving babies. So it went from being probably the least used tocolytic to the most used tocolytic for that reason. And tocolytic just means like toco is contracting, right, and I'm lysing it or trying to make it stop, aka lytic. Precardia, which of course if you're me, you can't really have because my blood pressure at baseline is 90/60, so that's going to be a bad choice for me. Indomethacin is a COX inhibitor, so before 32 weeks is used a lot, after 32 weeks is not because of the same reason you don't take NSAIDs. It can decrease urine output and hurt the baby's kidneys. And then terbutaline was by far the most commonly used tocolytic for a very long time. They even did pumps for a while. But it is not used very often anymore, unless it's in an acute situation. So if I have a baby that crashes, like their heart rate is 40, and I'm trying to stop their contractions as I rush them to the back, I may give them a dose of Terb because it works like this, but it lasts this long. And moms feel horrible. High heart rate, really rapid breathing. So we just don't use it that often. P-PROM. The big thing here is I want you to learn the definition, but it's essentially treated almost exactly like preterm labor, except they get antibiotics. So PROM by itself is premature rupture of membranes. Premature not meaning gestational age, premature meaning before contractions, so before the onset of labor. Preterm meaning the way we think about babies being premature. Okay, so that's why I want to be very specific there. So preterm, less than 37 weeks, premature before onset of labor, rupture of membranes. So if my water broke while we were talking right now, I would be PROM because I'm not in labor, but I would not be P-PROM because I'm 38 and 5. So management of P-PROM, like I said, is one of the, is very similarly managed to preterm labor, but it is super controversial. So history, physical exam, you want to make sure they're actually ruptured. The way that we do that is with a speculum exam. You test for nitrazine because things are very basic, or they'll turn blue on that like nitrazine paper, amniotic fluid will, whereas urine won't. But blood will turn blue, semen will turn blue. So it's not very specific. Ferning is where it looks like a snowflake on a slide if you looked under the microscope. It's pretty specific. It just can be confused with cervical mucus, which is like very hard ferns, kind of like 90-degree angles, whereas amniotic fluid, because it's salty, looks literally like a snowflake, like that typical what you would imagine an artist drawing. The most specific is actually pooling, meaning if you stick a speculum in there and there's all this water pouring out, like that's pretty obvious, right? Like if you can see it coming from the cervix, as opposed to the other thing is people pee on themselves, you know what I mean? Like you get kicked in the bladder, you don't have any control over it, and you know, it stops though, whereas your bag of water will just keep leaking because baby keeps making more fluid. So you do the same tests, you know, ultrasound, the same swabs. They still need steroids if they're under 34 weeks. This is where we don't go past 34 weeks though. But the big difference is antibiotics. So they need what's called latency antibiotics, meaning you're trying to create a latent period between the breaking of water and the delivery of the fetus. This is done by typically 2 days worth of IV medication followed by 5 days of PO. It's almost always acillin and then erythromycin. The one big change to this is actually there was a study that came out about 4 years ago that said a single dose of 1 gram of azithro is equivalent to this week-long course of azithro. So most people now do this exact course of AMP and Amox, but then they give them like a single dose of azithro. But the textbook answer is what I've written on here, and that's why it's there. Because I'm always trying to not be annoying. You do want to expedite delivery if they are infected. So remember how we talked about chorio at the beginning? If they rule in for that, keeping them pregnant for 2 weeks is not helpful to that baby. It's just going to make it septic. If they do not, then your goal is at least 48 hours, and a lot of times the average is 7 to 14 days that you're going to get. Remember, this can happen anytime between 24 and 34 weeks, and delivery is going to be dependent upon, does the baby tolerate labor when it happens, and what position are they in. So if your water breaks in your breech, or if your second child is annoying and is breached 38.5, you may get a C-section, you know what I mean, like regardless. And so you obviously don't deliver breech babies vaginally, despite the fact that she was head down on Wednesday. Not that I'm bitter. Depression. The biggest reason that this is brought up is because it is so, God blessed, common. And people don't like to talk about it. So this is, I will not spend much time because it's 4:30, but the biggest thing I'd like to tell you is make this normal for people. Don't be afraid to talk about it. Do not be afraid to ask about it. And know that it happens to 40 to 80% of women within the first 2 to 3 days are going to have some version of postpartum blues. It typically resolves within the first 2 weeks. They are sleep deprived. They're trying to figure out how to keep another human alive. It's hard. It is typically, do you guys learn that SIGI CAPS thing or whatever in depression? So it's the same thing, it's just in a postpartum person. Women at risk for blues and depression are going to have a history of depression. They're going to have some depressive symptoms during their pregnancy. Maybe they have a family history, or they're stressed about something. Do they have enough PTO? Do they have enough maternity leave? Do they have an idea of who's going to take care of their baby when they go back to work, especially if they're going back earlier? They have a NICU admission. So I had postpartum anxiety 100% with my last delivery. I had a 40-week, 5-day, 9-pound infant that went to the NICU and got a damn chest tube. I was a hot toddy mess. And had no idea. Do you know what I mean? Like, until I look back 4 months later, I was like, yeah, I was a little crazy. And my husband was like, well, I didn't want to say anything. But it's just there, you know. So any of those events, they had a traumatic birth. They had a C-section that they didn't expect. One of my patients, they had a baby, and the next day when their mom is driving up to see the baby, died in a car wreck. I mean, that lady is a setup. Right? So you have to follow these people. It is so common that they're now recommending a 2-week and a 6-week postpartum visit just to address depression. So anyway, I will stop beating a dead horse. But treatment typically resolves over time with blues, but depression, it does not. So if symptoms persist more than 2 weeks, that gets to rule in for depression. Those people typically need help. The prevalence is 5 to 15% of true postpartum depression, depending upon what study you read. The newer data says it may even be higher, more like 20 to 30%. It's hard because it is a shitty time. I mean, you literally get no sleep and your baby is like this gremlin that screams all the time and you love it, but it's just awful. And you can't figure out if you want to breastfeed or if you don't. And then in today's society, there's a whole bunch of blogs that are always going to be telling you that you are doing something wrong. Like, I don't know what it will be, but you will be doing something that is not appropriate. And so it's really hard for people. And so talking about it, figuring it out, having some way to screen, like we give people an Edinburgh postpartum depression score, like sheet. We don't tell them what it is. We just, like, we tick off the title. We say, here are some questions. Are you having these issues? And it says things like, do I cry more often? Or, and it's like, sometimes, all of the time, not at all, blah, blah, blah. So just having a way to screen is really, really important. If these people need management, it's not just about throwing a med at them. Now granted, you will give a lot of them meds, but it's also about little things like, have they literally not left their house in 6 weeks? Have they had no grown-up human interaction besides their husband or significant other? Because if they're only chatting with their own husband or wife while they're trying to like figure out nursing and all of those other things, that's, don't get me wrong, that's interaction, but it's just not the same as talking to someone you're not like significantly involved with. So they need to get out. They need to see sunlight. They need to have light therapy. They need all of those things. And then a lot of them will need some kind of medication. Typically we use Zoloft because it is the, which is sertraline, because it is the least excreted in breast milk for breastfeeding moms. But I will also freely admit, anybody with a history, I just ask them, did you take something in the past and did it work? Because if it did, it's probably fine. You wanna stay away from benzos for anxiety, and you wanna stay away from Paxil, both in pregnancy and postpartum, because those aren't good for babies. But the rest of it is totally fine. The other thing that you can always look at is there's a $10 app called the Infant Risk app that you can download to any phone. And it will tell you what category it is, both for pregnancy and lactation. And that would be my only other thing is please don't be the doofus that just tells somebody they can't breastfeed or they need to pump and dump because you've given them a med, because 99% of the time you're wrong. They can probably breastfeed. I spend so much time fixing that on a regular basis. So no, don't just guess. For people that are like hospitalized with like postpartum psychosis, those people may get electroconvulsive therapy or hormonal therapy, but that is not going to be very common. I've never seen it happen. These are my references. This is my one peanut. We've got another on the way. I'm so sorry for running behind.
Thank you.